Hello, everyone. Good afternoon. Thank you so much for joining in. You're most welcome. Content session today, organized by SIDS of Global in partnership with Ministry of Health. As you come in, kindly let us know where you're joining from. Can it in the chat section. Let us know where you're joining from and what are your expectations for today's session. Today we are going to be talking about hypothermia in the neonates. With me here, I have a team of experts and some are online. I'll be introducing ourselves. But for starters, I am Kwaga Init. I'm going to be the moderator of this session. Kindly let us know where you're joining from as we are about to start shortly. But before we start, we can dedicate this session into God's hands. We shall have a prayer from Midwife Barbara. Let's humble ourselves for prayer.
Let's pray. Dear Lord, we want to thank you for this afternoon. We dedicate this session unto your hands and for also the listeners who have joined in. May you enable us learn and also be able to prevent mortalities due to hypothermia in our respective facilities where we work. I pray this through Christ our Lord Jesus Christ.
Amen. Good afternoon once again. For those that have just joined in, my name's Init Kwaga. By profession, I am a nurse working with Mulago Specialized Women and Neonatal Hospital. I work in the NICU, and I'm very passionate about a newborn through providing quality neonatal care, through education, and definitely teamwork. I once again welcome you to this session. This session has been organized by SID Global in partnership with Ministry of Health. And today we shall be discussing about hypothermia in the neonates. So I have a team of experts here that will introduce themselves. I'll start from my right and proceed to my left. Dr. Sisi, kindly introduce yourself to the team.
Good afternoon, everyone. You are most welcome to the session. My name is Dr. Sisi. I'm a medical officer. I currently work with the St. Francis Hospital in Zambia in the neonatal unit in ICU, and I'm also the team lead in neonatal resuscitation team. Thank you. We hope to have a good time with you.
Thank you, Dr. Sisi. She's part of our experts here today. On my left.
Good afternoon, everyone. You're very welcome. I'm Rita Angela Naziwa, a neonatologist at St. Francis Hospital in Zambia. Thank you.
You're welcome, Dr. Rita. Midwife.
Thank you very much. Our participants online. I am called Barbara Mukachekwemoy. I am a midwife. I work at Kayunga Regional Referral Hospital, but I also work for the National Midwives Association of Uganda. Thank you.
Yeah, thank you, Midwife Barbara. Nice to meet you. We also have a chat expert. That's Dr. Mary Nachimura. If you're able to unmute yourself. And
Doctor.
Yes, go ahead, Dr. Nachimura.
From Kawempe National Referral Hospital. I'm a pediatrician. I also work in the neonatal unit.
You're most welcome, Dr. Nachimura. She's going to be our chat expert. I will want to start off with a few housekeeping rules. Like you've heard, Dr. Nachimura, she's going to be our chat expert. Let's be actively involved in the chat section in case you need some clarification. Feel free to ask any questions in the chat. Someone will be able to attend to all your questions And in case of any clarifications, they'll be able to do that. Another thing you need to know about is that all participants' microphones will remain muted throughout the session until when the part of the session where we shall have question and answers, that's when we shall be able to unmute you. So feel free to note down any questions that you may need the experts to throw on more light. We're also going to have a pre-test. This is going to help us assess our knowledge and skills in managing babies with hypothermia. Believe me, most of you have all lost babies due to hypothermia, and some of these deaths would have been preventable deaths. And if we have a pre-test, then we shall also have a post-test at the end of this session to evaluate whether learning has taken place. We shall also have, you may need also to raise your hand when the part for question and answers come in. Feel free to raise your hands. We shall unmute you and you'll be able to ask your question freely. Also, a CPD link will be shared towards the end of the session. So kindly request you to be with us until when the session comes to an end. The CPD point session will be shared towards the end. A pre-test is going to be shown on your screen or has already appeared. Kindly fill in. There are multiple choice questions. Kindly, let's answer those questions as we wait for more members to come on board. I hope you're able to see the question. In case you're not, kindly tap in the chat section, type if you're not able to see the questions. We shall have 3 questions. These questions are helping us to assess our knowledge. So far, 2 questions I think have popped up. I see someone saying he's not able to see the question. Jocelyn is not able to see. The questions will appear on your screen. We are going to resend Madam Claire. Sorry if you're unable to see the questions. So check on Zoom on polls and quizzes. Probably it could be there, those who that are not able to access them. Is anyone able to access the questions? Yeah, people are able to access. Yes, I can see. Some have got only one question. Keep on scrolling, keep on scrolling. Those that have not accessed the question, kindly check on quizzes. Yeah, someone has got 4 questions, that's good. There are 4 questions. Yeah, there are 4 questions, yes. Good, I think most of us have accessed the questions. Kindly also type your expectations in the chat section as well, so that we can keep track of what you could really be interested that the experts can really talk about. Thank you so much for those that are continuing to participate in the pre-test. So we are going to start today. Our session is about neonatal hypothermia. We shall define what neonatal hypothermia is. We are going to discuss the causes, the differentials of hypothermia. We shall look at delivery room management, that's prevention of hypothermia. We shall look at the complications of hypothermia and the management of hypothermia. So starting off this session, we shall have a case presentation by Dr. Sisi. This will help us to state the stage of learning and discussion. You're most welcome, Dr. Sisi.
Thank you so much, Sister Inedi, for the great introduction. So we are going to just look at the case of hypothermia for a baby that came through to our unit. And this was the baby of NI, who the age was at age of discharge, which was 13 days of life. He was a male. We admitted this baby on 5th of March 2026, and we discharged the baby on 17th of March 2026. So the baby stayed with us for about 13 days. So this baby came in at 1 day of life as a low birth weight preterm, who was delivered at 33 weeks by Ballard with a birth weight of 1.8 kilograms, and came in as a referral from Double Cure Medical Center for further management. So baby was delivered by emergency cesarean section, secondary to eclampsia, and they were suspecting IVR by ultrasound scan. However, this is a mother who had preeclampsia, had history of preeclampsia even her first pregnancy. However, she was noted to convulse on the way to theater. So at the referral site, before referral, baby had been managed for RDS, and they had put, that is respiratory distress syndrome, and had been managed on CPAP. They had loaded the baby with IV caffeine citrates at 20 milligrams. They had managed as a potential neonatal sepsis on IV gentamicin and IV ampicillin. And however, baby was noted to have worsening respiratory distress, and they opted for referral to our unit for further respiratory support. So at admission, we received a baby who was in severe respiratory distress, was grunting, and was transported. We noted the baby came in thin sheets, and we noted that the whole transport chain was not observed. So baby was diagnosed with cold extremities. So at initial assessment, baby was blue, was hypothermic, with a temperature 34.6, was jaundiced, with mild pallor, however did not have any dehydration, and the admission random blood sugar was 1.2 millimoles per liter. So as per respiratory system, the baby was in severe respiratory distress with a SARS 7-month Anderson score of 7 out of 10. Baby was tachypnic with a respiratory rate of 72 beats per minute. Was saturating at 98% on bubble CPAP with a PEEP of 6 centimeters of water. However, had equal air entry bilaterally and had occasional crepitations. So CVS had cold extremities, but our capillary fill time was less than 3 seconds, a heart rate of 119 beats per minute. At sound 1 and 2 had and were normal. So per abdomen, it was normal, full and soft. He had hepatomegaly of 4 centimeters below the costal margin. The bowel sounds were present with normal pitch and frequency. So per CNS, the baby was fully conscious, had a head circumference of 30 centimeters. Anterior fontanelle was narrow, but was normotensive with a good grasp and motor reflex, and with normal tone in all limbs. So at admission, we made an impression of a low birth weight preterm who was appropriately grown with respiratory distress syndrome. He had hypothermia, hypoglycemia. We were still suspecting potential neonatal sepsis. We also had neonatal hyperbilirubinemia, and we were to rule out torches because our baby had a hepatomegaly, so we still had to take more history. So the plan, we put the baby in a radiant warmer, and we took our temperatures every after an hour until we hit a target of 36.5 to 37.5 degrees Celsius. We gave a bolus of D10 at 2 mils per kg. We put the baby on bubble CPAP and we maintained our PEEP at 6 centimeters of water. We did a CBC, a CRP, a blood group, a blood culture. We did a PT-INR APTT. We also did TSBs, or total serum bilirubin levels, and we did a syphilis test. They had initiated the baby on IV ampiclox, IV gentamicin, so we continued with our first line as well. We maintained the baby on IV caffeine citrate at 18 milligrams per 18 milligrams OD, which is 10 milligrams per kg. And we had that TFI at 80 mils per kg per day of IVD10, which we gave 12 mils to our D. So the plan was to take mood history from the mother in regards to her ANC and touch screening. And because of our initial SAS of 7 out of 10, in consultation with the neonatologist, the plan was to give surfactant at 200 milligrams per kg and we were to monitor our vitals hourly. So in regards to the tests that we had done, our results with the blood group was AB positive. The CPC had an HB of 10.6, which was a bit low. Hematocrit of 30.6, low as well. We had normal platelets of 218, white blood cell counts of 9.15, and neutrophils were also okay. We had a normal CRP of 0.1. Our PT prothrombin time was slightly raised to 17.80. INR was as well raised to 1.45. However, APTT was normal, and we gave IV vitamin K, 1 milligrams OD, and that plan was to continue for 3 days. So our total serum bilirubin was 102.4. It was total bilirubin, with net direct being 9.8. And in calculation in regards with our photo line, the baby was 77.6 below photo line and did not require phototherapy. So 2 hours after admission, we did reassessment, and our baby was now warm at a temperature of 36.6. Our random blood sugar had improved to 5.1 millimoles per liter, and our respiratory distress had reduced from severe respiratory distress to mild at a 3 out of 10 in regards to SAS, and we had given our surfactant at 4.5 mils. So we maintained our baby on CPAP and our saturations were 99% on CPAP. So for follow-up, as I said, this baby stayed with us for a while. So between 6 and 8, on 8th, our baby was 5 days of life. Our gestation age was still 33 weeks by Ballard, and currently at that time, we were 33 weeks and 7 days. And our baby was stable. We had initiated feeds, and baby was tolerating the feeds, and we had as well initiated KMC even on CPAP, and mother was able to do about 8 hours. So we had completed our 48 hours of antibiotics. Blood culture was back, it had showed no growth, and also CRP was normal. The next examination, our baby was pink. We still had a tinge of jaundice. Our temperature was normal at 36.7. We didn't have any cyanosis, no edema, no jaundice, no edema, no dehydration. We were still in mild respiratory distress at a SAS of 1 out of 10. We had normal respiratory rates at 54 beats per minute, equal ANT bilaterally. Chest was clear. CVS was as well normal, with a pulse rate of 145, at sound 1 and 2 had a normal, and the CRT was less than 3 seconds. Her abdomen was normal as well. Normal fullness and soft. CNS was still normal, fully conscious, anterior continental normotensive, with normal tone in all limbs. We had a good moral and a good grasp. So our impression was a low birth weight preterm with RDS that had resolved. However, we still had neonatal hyperbilirubinemia that was resolving. So the plan was to continue with IV caffeine citrate at 18 milligrams OD. We continued with our kangaroo mother care, and we were to fill in our KMC score sheets. We were to win off from bubble CPAP to free flow. Our TFI had increased to 140 mils per kg per day, and our EBM was at 90 mils per kg per day, translating to 13 mils to hourly. We were still giving our IVD10 at about 7.5 mils to hourly, and the plan was to transfer the baby out of the NICU to our stable unit, which is a baby unit. And we did repeat TSBs that day that were 57 below quarterline, still did not require phototherapy. So from 9th to 16th, baby was still with us in our stable unit. 16th baby was about 12 days of life. Gestation age of 33 weeks by ballot, and currently the baby was 34 weeks and 6 days. So status, baby was stable. We were tolerating feeds, we were off oxygen and stable. We had initiated our supplements of bromide, folic acid, and enrich, and mother was doing more kangaroo about 10 to 12 hours. So we had done our screening cranial scan that is usually done at 7 days, and it was normal. An examination, baby was peeing, temperature was normal at 36.8. We didn't have any cyanosis, no dehydration. We were not in any distress. Sorry, that SAS is supposed to be a 0 out of 10. Respiratory rate of 44 breaths per minute, equal air entry bilaterally, and chest was clear. CVS was normal as well. Our pulse rate was 155 beats per minute. Heart 1 and 2 had a normal. Our abdomen and CNS were normal as well. So the plan or the impression at that time, we had a low birth weight preterm who was stable. And the plan was we had reached our full feeds. TFI was 160 mils per kg per day. And we were all giving it as EBM at 24 mils per 2 hourly by cup. So the plan that was to initiate breastfeeding and to do retinopathy prematurity screening, which was done. And it showed a row in zone 1 with anterior segment structures, which were normal. So we gave intravitreal Avastin that day, and we were to continue with the gut eye drops 4 times a day for about 2 weeks. And we were to continue with our supplements that we had already started, the Provita, enrich, weekly folic acid, and oral caffeine citrate was held. We were still to continue with our KMC and KMC sheet scoring, and we were to repeat our retinopathy prematurity screening by 31st of March 2026. So the last review that we did, that was on 17th, and the baby was due for discharge. We had a low birth weight preterm, 33 weeks by ballot, and at discharge we were 35 weeks. Our birth weight was 1.8 kilograms with a discharge weight of 1.77 kilograms, and baby was in a good general condition. The vitals at discharge, we had a temperature of 36.5. We were saturating at 99% on room air, a pulse rate of 134 beats per minute with a respiratory rate of 55 beats per minute. So the plan was to continue with the supplements, enrich, Grovit, weekly folic acid, gut eye drops, and what baby was to be reviewed in our neonatal follow-up clinic on 24th of March 2026. In addition to our group review, which was due 31st. So of course, we still educated our mother on the danger signs and encouraged her to bring the baby back in case any of them appear. So that was our case. Thank you so much.
Thank you so much, Dr. Sisi, for that wonderful case presentation. I think the case really shows how hypothermia is really a burden to us. It has clearly illustrated the complications of hypothermia, but I would not like to preempt my experts' discussion. Allow me have our first presenter, and that is Dr. Rita. You're most welcome, Dr. Rita.
Thank you so much, Init. So yes, today we want to indulge more into hypothermia in a newborn. What is our literature saying? What is the current situation? So that we are all on one board and we get better at managing this. So by definition, hypothermia in a newborn is when the newborn's temperature falls below 36.5 degrees centigrade. And temperature regulation immediately after birth is very, very vital. And it's a critical indication of survival of neonates. What's the normal temperature of a newborn? It is between 36.5 to 37.5 degrees centigrade. And the neonates are at increased risk of hypothermia because of many reasons. The commonest are their skin is thin, they have little subcutaneous fats, and because they are small, especially the preterms, it means their body surface area is quite huge, thus creating a big space for heat losses. And because the skin is fragile, there is increased evaporative fluid losses. And also, as we know, heat generation is from the brown fat, whereas the white fat in our bodies is for preservation of energy. The brown fat is supposed to be burned out so that we get the heat. Notably, this is very little in preterms and in neonates generally. So they have less reserve to burn to get heat. And temperature instability during transport, unfortunately, still remains a challenge, particularly in our low birth weight preterms, and especially in low resource income countries, of which Uganda is among. And the greatest risk of why this happens, especially in the first moments after birth. Intrauterine, the temperature is quite high, about 38 degrees centigrade, and that's normal, keeps the baby happy. When they're out, our environmental temperature is usually around 25 degrees. So you can imagine this baby who gets shocked from a nice, peaceful, hot 38, then all of a sudden is in a temperature of 25 degrees in our environment. So that is a very big change. And if we don't take precaution, this body temperature can rapidly drop by 2 degrees to 3 degrees in just about 20 to 30 minutes. Therefore, it's very important to prevent hypothermia as soon as possible in newborns immediately after birth by managing our warm chain, which we are going to be looked at. And this is evidenced by the many researchers that you see written down there. Next. I acknowledge this slide is from our project at Nsambya Hospital by Elma of the Breast Milk Bank. So this is a history of neonatal care and thermal control. The first neonatologist in the world, called Pierre Boudin, reported the importance of thermal control in the newborn. He reported that there was increased survival rates when infants' rectal temperature was maintained. He also noted that without the use of incubators for preterms less than 1.5 kilograms, the likelihood of death was close to 100%, especially if the temperature dropped to less than 32 degrees centigrade. This was further confirmed by a very good scientist, Silverman, who studied two contrasting environment temperatures upon time survival rates for preterm infants in the first 5 days of life. And what did he find out? Infants who were placed in incubators where the air temperature was at least at 1.7 had a higher survival rate than those whose controls were at 28.9 degrees, showing that maintaining the temperature is very important for survival. Looking at the epidemiology globally and in our setting, worldwide, the incidence of hypothermia in babies admitted in the NICU at admission, those who are very low birth weights, is between 31 to 78%. And in a study done in England, the incidence was at 14%. And having hypothermia, despite whatever the baby had, was an independent risk factor for death and even oxygen dependency. Coming down to the low resource, in Ethiopia, 67% of low birth weight and high-risk infants admitted to special care units, those who are outborn, had hypothermia. And back home, here in Uganda, at Nsambya Hospital, a research that was done about 7 years ago, the prevalence was as high as 87% in all preterms who were admitted. And after that, we had to take precaution. Currently, we don't have hypothermia in babies born in the hospital because of what we got that time. Excuse me. And in the most recent study that was done in Lira Regional Hospital, that's last year in 2025, 67.6% of babies had hypothermia within the first 2 hours of life. That is quite high. How about mortality and hypothermia? Admission temperature in the neonatal unit is a strong predictor for neonatal mortality. And this is very important that I'm going to say next. For each 1 degree decrease, just 1 degree in axillary temperature, it's associated with a 28 to 75% increase in neonatal mortality. Just a 1 degree decrease to going into abnormal temperature. And this was also shown in India, where hypothermia was associated with twice a higher mortality than in those who had a normal temperature. Therefore, there is need for meticulous thermal care as we manage neonates, whether during transport or resuscitation. So having heard about the mortality, I hand over to you, Enid.
Yes, thank you so much, Dr. Rita. Indeed, hypothermia is a burden according to our epidemiology that we see. However, let's continue with the discussion. Midwife Barbara to take us through the classification of hypothermia.
Thank you very much, our moderator. So according to WHO, hypothermia is classified into, we have normal temperatures, which ranges between 36.5 to 37.5 degrees Celsius. But when hypothermia sets in, the first will be mild hypothermia. When a baby who has mild hypothermia is seen at the facility, they usually present with temperatures ranging between 36.0 to 36.4 degrees Celsius. And then for moderate hypothermia, the temperature is usually between 32 degrees to 35.9. And at this point, the baby is already going into, the body systems are stopping to function. Then for the baby who has severe hypothermia, their temperature is usually below 32 degrees Celsius. And we need to note that when a baby has a temperature of 32 degrees, this baby is already in a medical emergency and really need to act very fast to save this baby. So what are the causes of hypothermia? We know that we have environmental factors and those that are related to the baby. So when it comes to the environmental factors, where the mother delivers from, that is the delivery room, if the temperatures are below 25 degrees Celsius, this baby is most likely to go into hypothermia. Then failure to dry the baby thoroughly. This is immediately after delivery. If we do not dry our babies thoroughly, they are going to present or they are going to get hypothermia. Then early bathing of the baby. It's recommended that we delay bathing up to 24 hours. There is no need for us to rush to bathe these babies. Then inadequate wrapping. We need to wrap these babies with warm clothes, with a cape if the mother has, or socks if they have. If they don't have, we can wrap them with warm sheets and possibly a baby blanket. Then separating them from a mother, we recommend that all babies should be skin to skin, at least for the first 2 hours with their mothers, but separating them too early, they're going to get hypothermia. Then exposing them during transport or during any procedure. You want to give babies treatment, you've not covered them well, you're exposing them to cold air, these babies are going to go into hypothermia. Then for baby-related causes, we have conditions like prematurity and low birth weight. As Dr. Rita has already explained, these babies do not have adequate fat to maintain their body temperatures. And it was also very evident in the case presentation by Dr. Sisi. We saw that was a preterm baby. It almost had all these risk factors. And then a baby born with birth asphyxia. These babies are struggling for oxygen. And for someone to maintain their body temperatures, they need adequate oxygen. As well, hypoglycemia and infections like sepsis. So why are infants at highest risk of getting hypothermia? Babies who are preterm, these are more at risk of getting hypothermia, as already discussed by the two experts. These babies have low subcutaneous fat, their skin is thin, and infants also who require prolonged resuscitation, infants that are acutely ill with infections, cardiac, neurologic, or endocrine problems. Infants also with surgical problems, for example, those with gastroschisis. These are babies that are at high risk of having hypothermia. So hypothermia alone has also other conditions that present like a hypothermia. Some of them include babies born to environments where there is heat loss, maybe your windows are open, and then babies that are having sepsis, babies that are admitted with hypoglycemia. Most times these babies present with symptoms similar to that of hypothermia. Then babies that are having intracranial pathology, for example, intraventricular hemorrhage, back trauma, those that have congenital anomalies like congenital heart disease, metabolic disorders, for example, organic acidemias, urea cycle disorders, fatty acids, and then oxidation disorders. And then endocrine disorders, babies with congenital hypothyroidism, adrenal insufficiency, and babies also in shock. These babies are going to have symptoms that are similar to those that have hypothermia. So how do these babies present, babies that have hypothermia? So for babies that have mild hypothermia, at admission, you're going to find that these babies have cold extremities, especially the hands and the feet. They are irritable and their feeding is poor. And then for babies that have moderate hypothermia, you find that they are lethargic, they are weak, and their suckling reflex is poor. And then also when you do their RBS, you're going to find that they have hypoglycemia. And for babies that have severe hypothermia, they will present with apneas, cyanosis, bradycardia. Some of them may be in coma or shock. So we have mechanisms of how heat is lost in these newborns, and there are mainly 4 ways. It is either by radiation, convection, conduction, or evaporation, and we're going to discuss them in details. So the first one is through conduction. So here, heat is lost when the infant comes into contact with a cooler surface. For example, you place a baby in a cold weighing scale or a cold bed, this baby is going to lose heat. When infants are wrapped in wet clothes or wet blankets, they're also going to lose heat. Babies that when we are examining them and then we use a cold stethoscope and also touching them with cold hands, this baby is going to lose heat through conduction when we do not observe warm surfaces or warm procedures. Then when it comes to radiation, these babies lose heat mainly when to cooler objects. The baby is not in direct contact with them, but they are surrounded with these cooler objects. These cooler objects could be either windows, or they are near doors, or they are next to walls that are cold. So these colder surfaces increases the risk of these babies losing heat through radiation. So when it comes to conduction, here heat loss occurs when the infant's body heat is lost to cooler air moving around the infant. And this cool air moving around the infant is usually happens when windows are open, doors are open, fans are on, air conditioners are on. Sometimes when the baby is in the incubator and we leave the incubator open, or the portholes of the incubator are opened, the baby also loses heat. So when we also give when cold oxygen is blown over their face or over their body, they lose heat. And heat loss is always accelerated when temperature of the air is colder, especially during rainy season or cold weather. The airflow here is very high and it increases the risk of these babies losing heat. Then through evaporation, heat occurs as moisture on the infant's body surface or from the respiratory tract vaporizers. And this one, at the delivery room, if the baby is not thoroughly dried, or we use wet clothes to dry these babies, or they are not removed immediately, the baby is going to lose heat. If the infant's skin is not in contact, is not intact, here, maybe the baby is presenting with a large wound or conditions like spina bifida or exomphalos. We know very well these body organs are exposed. So these babies are not going to be able to maintain their body temperatures. So they are going to definitely lose it through evaporation. Then if an infant is a temperature, this one we've already discussed, and it's because of the thin skin. And here they have inadequate subcutaneous fat as well. Then if oxygen is not warmed or humidified, then if the windows are open, and we always encourage that our labor suites or delivery rooms, windows should always be closed. So how do we manage hypothermia? It's recommended that the best management for hypothermia is prevention. So if we can prevent hypothermia, it's very key. So how are we going to prevent hypothermia? WHO has recommendations, and these recommendations are about 10, and they are interlinked. One of them is having a warm delivery room. Our delivery room should be having a temperature above 25 degrees Celsius. The doors of the delivery room should be closed and windows, and any air fan or cold air currents should be also avoided. And then warm resuscitation. As we are resuscitating these babies, we need to ensure that all the baby towels or sheets that we are using, they are pre-warmed. We use a radiant warmer if it is available when we're doing a resuscitation, or a warm resuscitation surface. The other is immediate drying of the baby. We emphasize that as soon as this baby is born, we need to dry them immediately. And this drying should be occurring before we deliver the placenta. And if possible, remove the wet towels quickly and replace them with warm towels. And here we're going to prevent heat loss by evaporation. So the next is maintaining skin-to-skin contact. As soon as we deliver this baby, put this baby on the mother's chest. After drying them thoroughly, let them remain on the mother's chest. This maintains their temperature. It also promotes bonding and supports breastfeeding. In addition to that, it also stabilizes breathing and heart rate. And here we emphasize kangaroo mother care, especially for the babies that are preterm. Then the next one is early initiation of breastfeeding. Breastfeeding should occur within 1 hour. We saw that in our causes, hypoglycemia causes hypothermia. So we need to initiate breastfeeding early, within 1 hour, in order for us to provide calories for this baby, which will enable heat production and prevent hypoglycemia, which will lead later on to hypothermia. We also talk about delayed bathing and weighing of the baby. Bathing should occur at least 24 hours, and baby weighing can occur when the baby is stable. Then the next one is appropriate clothing and bedding. If the mother has a hat or a cap or socks, we need to put them on. But if they don't have, we can just use the warm clothes to wrap these babies very well, and they should be warm, and add in blankets. And just to note, the head accounts for the major heat loss because it has a large surface area. So then the other one is rooming in. Rooming in is where we keep the mother and the baby together. So we avoid unnecessary separation as much as possible. Keep the mother and the baby together, and we emphasize keeping them skin to skin. And then the next is warm transportation. When we're transporting these babies, maybe to a niche from the delivery room, we need to ensure that these babies are well wrapped, they're maintained on skin to skin, and if possible, or if available, we transport them in incubators. And then the last one is training and creating awareness. It's very important for us to train all health workers that conduct deliveries, those are midwives and the doctors in the delivery room, on how to prevent hypothermia. And we shouldn't forget the caretakers of these babies. They need to be also educated on the danger signs of hypothermia, thermal care, and how to maintain warm chain practices. So what about a preterm and the delivery room? there is need to pay special consideration for a baby who is a preterm, especially those that are below 32 weeks of gestation. These babies are not dried at birth. We leave the vernix caseosa on. This reduces heat loss because their skin is immature. And it's important also to place these babies under a plastic or a polythene bag such that they don't lose a lot of heat and maintain their temperature. And this should remain on until the temperature is stable. So we leave the polythene bag until the temperature is normal. That is between 36.5 degrees to 37.5 degrees Celsius. For preterms, we emphasize that at least we need to cover their heads with a cap and also their extremities with socks, and also encourage warm transport. So that is how a preterm plastic bag or polythene looks like for a baby who has a preterm, and you can see the baby is wrapped inside there. So that is just another picture showing us a baby wrapped in a plastic bag. So why are preterm infants having a higher risk of hypothermia? Preterms have difficulty in balancing heat loss with heat production. And this is because they have a large surface area compared to their body mass ratio. Their muscle tone is weak. And also they have thin, immature skin. And this is a decreased barrier to water evaporation. This decreases barrier to water evaporation. Then we also have increased evaporation and then poor ability to vasoconstrict in the first few days of life. They also have decreased amounts of insulating fat and reduced amounts of brown fat. So I'm going to call upon Dr. Rita, our expert, to pick up here. Thank you.
Thank you so much, Barbara. Going to the womb transport, as she presented, it's part of the womb chain. So womb transport from the delivery room to the neonatal unit or the postnatal ward is very vital. If a baby is not kept warm during transport, there is significant drop in temperature. And as we said, the temperature can easily drop between 2 to 3 degrees in just 30 minutes. And yet just a 1 degree drop increases the mortality by 75%. And therefore there are innovations, and some are very natural, to improve warm transport. And one of them is the exothermic mattresses. So about exothermic mattresses, different researchers have proved their benefits. Brennan, one of the top researchers, reported that there was successful use of these exothermic mattresses to maintain body temperature between birth and admission to a neonatal unit. Another one, called Guthrie, placed neonates who are between 34 to 40 weeks who are born in cesarean on what we call activated gel mattresses. And all the babies in the study group were able to maintain acceptable temperature between 36.6 to at least 37.3 degrees centigrade. Other types are heated water-filled mattresses. They also help. These are even in the lower resource settings. They are easier to be made. And thermal mattresses have been used even in the most vulnerable while transporting babies from hospital to hospital. And they have proved to improve temperature and reduce conductive heat losses. In another big research by a gentleman called Johan, 91 infants were studied when they were being transferred from a lower health facility to tertiary institutions. And these infants were compared by, first of all, documenting temperature on arrival to that referring hospital, before departure from that referring hospital, and on arrival to the tertiary neonatal intensive care unit. And all the infants had good temperature control and stability in their body temperature when they were measured, which was a very good thing. Because sometimes mothers are unwell and maybe they are not available to do the main skin-to-skin care. And let's not forget, even in the absence of these exothermic mattresses, which may not yet be readily available in most of our hospitals in Uganda, let's never forget skin-to-skin and use of the plastic bags for preterms. So this is how an exothermic mattress looks. One of the most popular is the Womilo, the yellow part, and you can see the white part inside the yellow bag. That is where that gel-like mattress goes under. And before you put it, you should have put it in boiling water, and then it gets nicely heated up. Then you put it under that white carpet you see in the yellow bag. And it's quite comfortable and holds the baby in one place, in that even if you need resuscitation, you can do it comfortably. It's almost like an artificial KMC bag for a baby. Next. So what is the evidence saying? What is research saying about this Womilo? A study in India in 2013 was done among 20 preterm babies and low birth weight preterms. However, they didn't have any other morbidities like congenital heart disease or anomalies. And when they were placed in Womilo bags, they were able to have stable temperatures for at least 3 or more hours. And that is time that can be adequate while you're transporting a baby from facility to facility. And even if it's within the same facility, the minutes lost as you transport a baby can lead to bad hypothermia. So where we can advocate and get Womilos and get those exothermic mattresses in our settings. So that is how the baby will be positioned. So below the white in the middle where the baby's body is, under it lies the gel, the one that gel bag that you saw mattress that is put in the boiling water to heat it up. And then the baby will be nicely cuddled up and tied up well with what you see on the side so that they're in one place. Next. So how do we manage hypothermia in case we have diagnosed it? Barbara talked about the prevention, which is the ideal. So if a baby has mild hypothermia, as we classified earlier, the main thing is to rewarm the baby for all types of hypothermia. But if it's mild, how do we rewarm the baby? Priority is cheap, skin-to-skin care by the mother. Though I've seen even some health workers doing KMC for mothers who are very sick, and it is touching, but those are in developed countries where it is probably 1 nurse to 2 babies. Then, of course, warm clothing and cape. The room must be warm. Barbara has emphasized that. And breastfeeding. Most studies have shown that breastfeeding is a protective factor for neonatal hypothermia because it encourages the skin to skin. The breast milk is nicely warm. And of course, you're giving more glucose, which is going to generate heat. How about if the baby has moderate hypothermia? That means we need to escalate to a radiate warmer or an incubator, whatever is available in our setting. But if it's not working, still we do skin to skin if we don't have them. And then we have to cross-check, is the oxygen warm? Is it humidified? So priority, even if we have few in our facilities that give maybe the warm humidified, the priority babies are those with moderate to severe hypothermia. So let's prioritize our babies. A stable baby shouldn't be on warm humidified oxygen if you have very few in your units. But however, that is what is the standard. Whether the baby is stable or not, we should give warm humidified oxygen. Then, of course, continuous temperature monitoring should continue for a moderate hypothermia, and never forget to check the blood glucose, because if a baby is hypothermic, they utilize a lot of glucose and they end up having hypothermia, and the cascade will continue if we don't correct the glucose levels. How about severe hypothermia? Severe hypothermia is an emergency. We look at it the way we see a child, a baby convulsing. It is that serious. It's an emergency. It's a red flag. And if we have a neonatal intensive care unit, we should escalate. If the baby was in a stable unit, transfer them to the intensive care unit. And they should be under the best incubator in that unit, which is servo-controlled, because we don't have many of those. Please, we need to monitor the cardiorespiratory, because their respiration can easily be depressed and they can easily get bradycardia. And then when we are warming, we have to rewarm slowly. This is where we don't rush, that if the baby was at 33, now we want to heat them up very fast within 10 minutes. If we do it very fast, it can cause complications because the body had gone almost into a docile mode. And if you overactivate it, we are going to activate chemicals within this body that might even worsen now the cascade, and you may just see your baby having seizures. And then we need to monitor for the complications, especially in severe hypoglycemia, and correct them immediately, especially hypoglycemia. That said, we should evaluate and treat underlying causes. Why is this baby this hypothermic? So we are going to go into complications. And as we go into complications, we are going to first understand how these complications come about. So when a baby has hypothermia, how do they respond? One, the body goes into a defensive mechanism. You've seen all of us, especially the men, adults, when it's too hot, you will see very dilated vessels all over the muscles. You see the vessels dilated, even on the face, you see them so enlarged, because there is dilatation. To lose heat, now with coldness, the opposite happens. The blood vessels are going to vasoconstrict. Why? Because that chemical, norepinephrine, is released. And we know it is responsible for vasoconstriction, where the blood vessels are narrowing. So when the blood vessels narrow, of course, this leads into peripheral vasoconstriction and even pulmonary vasoconstriction. So when this peripheral vasoconstriction happens, that means that you're avoiding blood reaching the skin surface where heat loss occurs. And therefore, blood will stay at the core, deep within the body, to aid in heat conservation. However, if this vasoconstriction is prolonged, it will lead to reduction in the blood flow, because remember, your blood vessels are now so narrow. This means that the blood flow reduces. And when the blood flow reduces, that means the oxygen delivery to the tissues reduce. And when oxygen delivery reduces, we go into different mechanisms to release energy, which is the anaerobic. Anaerobic metabolism means there is no oxygen, but now the body is using other means to release energy and conserve heat. And this will lead to production of what we call lactic acidosis, which is a product of anaerobic metabolism. And the more lactic acid we have, it increases damage of vessels and organs. So what else happens when norepinephrine is reduced? There is increased brown fat metabolism. Remember, we said brown fat is what leads to increase in heat production. So when the norepinephrine is released, it helps in burning down brown fat so that more energy is released. And this is the survival mechanism of babies, because their system, they don't shiver a lot, which we adults used to make heat. What else do babies do when they are very cold? Usually they will end up crying. There is increased muscle activity. And they will flex. You will see that baby flexing, especially the term babies. The poor preterm babies do not even have that muscle activity. They are not able to flex. So when they flex, they are trying to retain their heat. However, when this muscle activity increases, they even use up more calories, more of their glucose, because they are flexing. And in that process, it is a longer cascade, because now they need that glucose to help in generating more heat. And yet it's being now wasted on the flexion, which is also one of their methods to conserve heat. So this is a pictorial that summarizes what I've talked about. If you start from your left, there is pulmonary vasoconstriction. And this also will go into increased right to left shunting. Some babies will even end up with worsening PPHN, what we call persistent pulmonary hypertension, which presents with more cyanosis. And because of the peripheral vasoconstriction, that means blood is not reaching most of the body parts, even the extremities. These babies will end up looking blue, cyanosed. If the extremities are blue alone, it's what we call acrocyanosis. And we've seen our preterm babies with blue feet, blue hands. Usually it's hypothermia. Warm them up and they get pink. So now let's go into the complications as we've understood how a baby reacts. The first one is hypoglycemia. Why do they get hypoglycemia? It's because of increased glucose utilization to produce heat. They can also, and our baby that Dr. Sisi presented had an RBS of 1.2 because they were very cold at 34.6. They can also have abnormal clotting factors or processes. And this is because when there is hypothermia, the enzyme activities, those enzymes that help in controlling bleeding in our bodies, reduce. And when this activity reduces, the coagulation cascade or the bleeding capability of the body reduces. And these babies can end up having clinical bleeding, or the results will be abnormal, like the baby who was presented. The prothrombin time, one of the tests for checking the way the body is controlling bleeding, was high at 17, and the team had to give vitamin K. There is also increased risk of respiratory distress syndrome in the preterms because hypothermia, those low temperatures even impair surfactant production. And because of the ongoing vasoconstriction, these babies also get and the low clotting factors, they can easily bleed from their lungs. And once they do that, it is one of the worst indicators of mortality. They also get feeding intolerance and hypothermia. Interestingly, also increases the risk of infection because when the temperature in the body is very low, it impairs the immune function. The white blood cell function reduces. And two, because of that constriction of the vessels, the blood flow to the tissues reduces. And with that, there is also impairment in delivery of the immune cells. And that is how the babies are at higher risk of infection. And also the baby Sisi presented had signs of infection. They can also get cold injury and they end up getting fat necrosis. We've seen babies who have hardened kind of swellings, usually at the back, kind of woody, hardish, and painful. It's usually a result of cold injury. So I talked about the anaerobic respiration when all the glucose has been, the oxygen demand is very high, leading to metabolic acidosis. And when we have consistent or persistent metabolic acidosis, usually these babies will end up having shallow breathing. And if this persists, at the end, they can end up having apneic episodes. But of course, before that, in compensation, before the shallow breathing, they will start breathing very fast, just like the baby Sisi presented. the breathing rate was as high as 72 breaths per minute. But when this continues with the worsening acidosis, the breathing gets shallower, and then they end up into apnea. And even if you're resuscitating such a baby, if we don't manage the temperature, if the hypothermia is there, it interferes with improvement of a baby you're resuscitating. And you will wonder, I'm bagging well. Why isn't this baby's breathing coming back? If we forget warming up the baby, the breathing does not respond well because of ongoing metabolic acidosis. And it can also lead to decreased level of consciousness, because if you're using up lots of oxygen to keep warm, then these babies end up getting hypoxia and hypoglycemia, meaning also our brain is not receiving enough glucose, first of all, and the oxygen. Then this baby can present with reduced level of consciousness, and we shall start thinking, is it HIE? No, sometimes it's just hypothermia. In the long run, it even affects the increase in postnatal weight loss, in that the weight loss increases postnatally, or even the weight gain is so slow. When Sisi was presenting, I was looking at the discharge weight of this baby. It was 1.77 at 13 days. Yet after 10 days, all babies are supposed to be gaining weight. This baby was born at 1.8, but because had a bumpy ride of hypothermia and of course resulting infection, hypothermia will affect the rate at which these babies gain weight, because this baby is using up a lot of the glucose. Instead of using the glucose to grow, to put on weight, they are using it to maintain their heat, so the weight gain is slow. Now this is very interesting. Hypothermia even causes jaundice. How? We talked of the brown fat, which is one of those options to make heat when a baby is very hypothermic. So when brown fat is being broken down to give that heat, it releases some special fatty acids. And these special fatty acids are going to compete with bilirubin. Remember, bilirubin, which is why we have jaundice, goes out of our bodies, or the baby's body, by being carried on albumin. But now these special fatty acids that are given out as the brown fat is being broken down to release energy also compete for the same albumin. So what happens? The bilirubin will stay, lingering in the bloodstream, so that jaundice stays for longer, or even a baby who wasn't meant to get jaundice ends up being jaundiced. And if we don't correct, we are going into more episodes of hypothermia, going into severe hypothermia. Our brain is not getting enough glucose because all the glucose is being used up to release heat, and the oxygen is being consumed to make glucose. As the level of consciousness worsens, this baby is going to have seizures that we shall panic and call HIE, but it started because of hypothermia. And when we don't react faster, like I said, severe hypothermia is an emergency, this baby will die. He will die. And in hypothermia, we have what we call the lethal triad, or the death triad. So what is this death triad? Hypothermia, worsening hypothermia, that leads to worsening acidosis and coagulopathy. So once these three meet, and it starts with hypothermia, you go into anaerobic metabolism because you've used up all your glucose and oxygen. Then next is the coagulopathy. Once coagulopathy sets in clinically, babies can go into pulmonary hemorrhage. This is what we call the death trap of hypothermia. So let's go back, fight hypothermia. Now that we've understood the complications, we thank you so much for listening in. And just to say, when it comes to a newborn, every degree in the temperature matters. Let's keep our newborns warm. Thank you so much.
Wow, thank you so much, Dr. Rita. Thank you so much, our expert, Barbara, for that amazing discussion that you put up about neonatal hypothermia. Thank you the participants for actively engaging in the chat section. And those who still have questions, feel free to continue submitting those questions. I think we can share some flowers or clap for our experts. I think they have really done a good job. Thank you so much. I'm sure by the time we end this session, we shall not go back the same. I personally have appreciated how, if I can relate the case presentation to what the Dr. Rita and Barbara have shared, clearly neonatal hypothermia is an emergency. As medical workers, we should not just maintain the status quo in managing these babies. If you are doing a ward round, whether you're a nurse and a doctor, early recognition of a baby with hypothermia is very crucial. Nothing works apart from keeping this baby warm. Even though the baby is warm and you do cold, and you do all these other interventions and the baby is cold, all your interventions will be in vain. I would want to first comment about the case that Dr. Sisi shared. Indeed, we've seen that the baby came in, this was a referral. So I want really to comment about transportation. We all agree that most of our deliveries are happening in the peripherals. And how are these babies being transferred to the referral sites? How are we transporting these babies? That is something as health care workers we need to think about. Are we just putting the babies in baby cots and just take? Sometimes the mothers are stable, they can be able to offer skin to skin. Let's transport the babies skin to skin. Fine, I know that the best transportation of a baby is during the utero, but sometimes it may not happen, like our case that we had. How was this baby transported to Zambia, maybe? It's very important on how we transport these babies. And the other thing that I wanted to comment about in the early recognition, sometimes the things that we use, the baby is getting cold and maybe the incubator is faulty. Maybe the skin probe is not attached to this baby. We need to be able to recognize that before we proceed with anything else. Find out, is the probe attached in the right side? If at least most of our facilities have these incubators in place, those that don't have, at least we have warmers. And we have seen in today's presentation that when a baby is less than 1.5 kilos, at least let's admit these babies in incubators. Warmth comes first in everything that we do. The other thing I would want to comment about the preterm and term babies drying and not drying. We've heard from our experts, they are saying that our babies that are less than 32 weeks, we are not drying. We are wrapping them in a polythene and transporting them maybe to the NICU, wherever they are going to be managed from. Maybe I will ask one of my experts here present, maybe Dr. Sisi. She can comment about yes, we have seen that these polythenes do as well, but however, the availability of these polythene bags are not really there in most of the hospitals. How I have seen a practice where we are using bin liners, the yellow bin liners, red bin liners, we are wrapping these babies, these preterms, and transporting them around. I would appreciate your comments on that.
Thank you so much for that. That's a subject we can table and discuss till tomorrow about very low birth weight preterms, especially less than 32 weeks that are delivered. Okay, should we put in a bracket of delivery room stabilization, because warmth comes first, especially for them. versus resuscitation versus what kind of polypen should we use and the availability of the polypen we should use for these babies to destabilize the delivery rooms. For places, of course, I would speak for my hospital, at least we have the polypen bags ready. I mean, we prepare early and we've
For those that do not have this
yes.
nice intervention.
So for the places, that's what I'm saying, that from our side, yes, but now how about the places that do not have, and they're saying that accessibility is also hard. So I don't think, maybe doctors will also add, they don't think there is really a special type of polypen that we should use. But the most important factor comes in a color as well. Because bin liners, most of them are red, yellow, and black. Imagine every baby that we receive is not breathing. Some of them are not breathing, right? You still need to resuscitate these babies.
Yes.
So we are saying let's get transparent polythene. I think the quality, I don't know, there's foil versus the one that has a thick, I don't know how to call it, a thick layer. Yes.
Okay.
Then there's another one as well. I think one I've seen in Kawempe. I don't know. But for me, I think I would still say it's transparent, it's available. Please use that one and transport this baby well. The issue about transparency is that you're able to resuscitate your baby when you're seeing this baby's response to your resuscitation. Imagine you have a yellow one, you would not really determine whether is my chest moving during resuscitation or not.
Thank you
Is
so
my
much.
color better like that?
Dr. Rita, would you like to
Yes,
compliment?
please. Thank you. Is it possible to go back to the presentation, the slides on the plastic bags? So they can be very basic. Like what we use in Zambia Hospital, it's basic. It's just a transparent polythene in a shape of a bed sheet. Very simple like that. And even in Cape Town, they were using something simple like that. So what do? You just lay it on the bed. Okay? Just like that baby. The next one? Yes, that one. This baby is in the unit right now. Dr. Sisi was stabilizing this baby last night. So you can see that Kavera is on top. That's the baby bed. So you just put it on top of the baby, but balance it with maybe a box of gloves on the side so that the baby has space to wiggle around and breathing space. And then you hold it below the mattress. Very simple like that, and it still does wonders. Let's go to the previous one. However, other colleagues in neonatology have gone further to improvise. Thank you, Claire Himsiwe, my good friend in Lago Specialized. She's worked with some colleagues and they have made it even nicer looking and even more containing for the baby. That is another type of plastic. This is a plastic bag. That's why we say put baby under a polythene or in a plastic bag. So both of them are giving the same effect. And it's not expensive. Sisi and I can find out about the cost of the very simple one we use in St. Francis. And then I believe this can be easily availed by our ministry. They are not so expensive. And by Seed Global. Thank you.
I love that. I think we have representatives from the ministry and you're taking note of that. I think an average price goes between 25 to 30,000 each plastic bag. So we are saying once you deliver the preterm, wrap in a plastic polythene, then transport this baby, let's say, to the NICU. If, for example, the incubator is not yet warm enough, maintain the baby in that plastic wrap. Once you feel that the temperature around is warm, you can remove the plastic wrap and continue with your basic care. The other thing that really stood out for me in this presentation was the admission temperature. I don't know how many of us take admission temperatures. I don't know how many of us do that, but I think this is a very important quality improvement initiative that we can take up as different hospitals. All the babies that are admitted in our newborn care centers, at least let's endeavor to see that we take their temperatures. I believe thermometers are available. Let's try to make sure that we get to know if you're receiving babies and they're always hypothermic. We give prompt feedback to these health facilities. We are receiving your babies, and most of these babies are hypothermic. And like we've seen, hypothermia affects almost all different organs on this baby. And we want to see that these babies are surviving, not even just surviving, but they are thriving. We don't want to see babies ending up with IVH grade 3, and we keep on increasing numbers in the neuro clinic. We need to see that all these numbers are going down. So I will go again. I will go to the chats for those that have been asking certain questions that we can actually throw more light on. I think one of the questions that really came out a lot was about polythene bags. I hope everyone is happy to hear from that. The other question another comment I want Dr. Richard to comment about is managing babies with HIE vis-a-vis hypothermia. Most of us know that when we have an HIE baby, we know about the cooling part. How should the health workers here resuscitate these babies, yet we are telling them warmth comes first? Is there any modifications for a baby with HIE during resuscitation?
Okay. Thank you so much, Enid. It's about resuscitating a baby who has HIE. If the hospital is not formally with a protocol to do therapeutic hypothermia, they should be resuscitated under normal temperature. Please, let's not make these babies hypothermic if we are not officially doing therapeutic hypothermia. And to do therapeutic hypothermia, you must have the right equipment, you must have the right protocol in the unit. But still to say, because Uganda is really growing in neonatology and the ministry is supporting us strongly, countries like India have innovated therapeutic hypothermia machines that are available for low resource. So I believe regional hospitals in our country can afford to get at least therapeutic hypothermic machines so that we can promote these protocols. Take home, you don't have a cooling machine, resuscitate babies with HIE under normal temperature. They shouldn't be hypothermic. Don't keep them cold as you transport. Keep them under normal temperature. Thank you.
Thank you so much, Dr. Rita, for that clarification. I would like to call upon Dr. Mary. She has been very active in the chat, answering some questions. I believe she has certain pertinent issues that she can talk about. You're most welcome, Dr. Mary. Are you able to unmute yourself?
Yes, I can. This has been really commented about, but can you hear me?
Yes, we can. You're loud and clear.
Yeah, so most has really been talked about the emphasis of thermal control, knowing the risk factors, knowing the normal temperature, and knowing the different types of hypothermia, the different classifications. How to intervene has really been talked about. Mainly what I would really want to talk about is how do we reach out to each and everyone. This is what we are doing currently. So we are training, we educating, empowering, increasing awareness. Because what usually kills our babies out there, it's usually the lack of knowledge. I believe if we can reach, if the people we have taught now really go ahead and implement and already teach more in their health units, we shall have reached a very large population and we shall reduce the incidence of hypothermia, and we may also see that our rates of death due to hypothermia also going down. The other is our facilities. How do we advocate? We need to advocate for ongoing thermal control because all we have done is mainly emphasize more around the time of birth. But we also know that there are other babies who still go on to develop hypothermia after the time of birth. So after 2 hours, after 24 hours, even when they're discharged out of home, how do we encourage and empower our mothers? This needs to start all the way from the health facility. Even during antenatal care, we need to include educative services to these mothers to know the risk factors, to know the symptoms of when the babies are really hypothermic and how to intervene when their babies are hypothermic. Simple things like touching your baby's feet, that they are cold, and observing the baby breastfeeding. Encourage rooming in of the babies with their mothers. Babies should not be kept separately. They should be with their mothers. Rooming in. Educate them of how to perform kangaroo mother care so that they can be able to continue it even at home. If we can start it within the hospital, the better. Our health facilities, we need to advocate for these KMC spaces. So the friendly rooms where they can be able to provide the kangaroo mother care so that they can be able to go on at home and continue the kangaroo mother care. The issue of transporting the babies has really been touched upon. The other is our equipment and maintenance of our equipment. You may find that we have many of these equipments, but we do not know how to control or monitor the other babies on the what? On the radiant formers. And they may getting complications of hypothermia, which also is another killer. So job training, supervision, regular monitoring of our patients, evaluation. So we need to do some studies. Data is very important. What is the incidence in your health facility? What interventions have we put around to really control these equipment, these rates of hypothermia in your health facilities? So we need to just advocate for these equipments, how to use them, educate the health workers, educate our mothers as well, so that we can be able to maintain this thermal control. Let us practice the WHO 10 practice over warm chain. And by doing so, we shall be able to reduce our rates of hypothermia and also the rates of mortality due to hypothermia. Thank you so much.
Chain, as recommended by DH. I think this is something that we need to have even in our delivery rooms, in our newborn care units to help us keep. It reminds us on what initiatives we can do when we are faced with a baby with hypothermia. Dr. Rita, I would like to supplement more on what Dr. Mary just shared.
Thank you so much. Dr. Mary talked about equipment. Sometimes it's faulty, or we may not be certain on how to set them up. So basically on incubators, we should be cognizant that it is not just what we feel like that we should set on an incubator. There are protocols or guidelines that guide us on which weight category and which temperature setting should be on the incubator. And we don't need to cram them. These can be printed and put in our neonatal units. Because if a baby is 1 kilogram, we should set the incubator at a particular setting, usually higher, like at 31 degrees centigrade. Then if a baby is about 1.5 kilograms, it is even lower. We shouldn't cram them. You can look on the internet. If you can't get them through Seed Global, we can even provide them. Very easy to print out, put them in your unit so that these babies can keep warm. Thank you.
Thank you so much, Dr. Rita, for that supplement. Before we are going to give some time for the participants to ask some questions. However, before we do that, I would like our expert Barbara to comment about one of the things that have come out was what messages can we give to mothers in order for them to notice and manage hypothermia while at home.
So thank you so much, our moderator, Ines. First of all, when we are educating these mothers, it's important to teach them about the danger signs. That is when they will be able to recognize that there is a problem. And in hypothermia, we are going to teach them that when a baby presents with hypothermia, most times they are going to have cold feet, cold hands, and then also they will not be able to feed well. If they also notice that their baby, their activity has reduced, they have a weak cry, and also reduced feeding. Their skin color sometimes changes, as emphasized by doctor. They will have blue extremities, and sometimes they may have breathing problems. So we emphasize and teach them about the danger signs. When they've identified this, what are they going to do? Let them ensure that they place this baby on skin to seek and seek immediate health care. And then also ensure that while at home, they cover their babies well so that they don't get hypothermia. We encourage them to breastfeed their babies frequently. And also the room where the baby is should be kept warm, just as we keep the delivery warm, even while at home, the room where the baby is should be warm. The other thing is, as soon as they finish also bathing the baby, they need to dry these babies thoroughly well at home and then cover them with warm sheets. But most importantly, recognize the danger signs and come to the hospital. Thank you.
Thank you so much, Barbara. I'll just make a small comment on baby bathing. On discharge, one of the things that we need to tell these mothers, we need to delay bathing. If a baby is less than 2.5 kilos, let's not dip them into basins and bathe them. That abrupt change in temperature, I have seen some babies succumb to death because of that. So right now, I will allow the participants to ask questions directly. You can raise up your hand. Once we pick on you, your microphone will be unmuted and you'll be able to ask your question. I see a hand already up, Dr. Joseph. Kindly go ahead and ask your question.
Yes, thank you for the nice presentation. I'm calling from Lira Regional Referral Hospital. Well, I am in the whole presentation, I was looking at the picture of Health Center 4, picture of Health Center 3, faced with such a baby in a bad state of hypothermia. By the time they leave the referral unit, the healthcare worker might not even think it is hypothermia causing the changing condition in this child. So my attention goes to system strengthening. It might have not been the package for this presentation, but I think there are issues to pick up from your presentation, which we can use it in the line of health systems. One, we talked about the issues of the room, the warm room, that is infrastructure. We talked about that plastic bag, that is what? And equipments or supplies. Now, when we look at our supply chain, look at our budget area, we look at our
Dr. Joseph, we are losing you. Your network is not stable enough.
We look at our leadership. We think that the healthcare worker, the midwives who are in this forum, my message is to them, try to get involved in every step.
Dr. Joseph, your network is not stable. We are losing you. You're breaking. but it seems his comments mainly about policies and systems. Yes, we understand health center fours, health center threes, and this is where our big customers really come from. They are the most referring sites. I think this is something that the Ministry of Health needs really to appreciate. And we, as advocates, we need to continue advocating for the well-being of our newborns. Then, as he also mentioned something about midwives being innovative, like you've heard Dr. Rita mention one of the midwives who's really very innovative in these things. So let us come up with different quality improvement projects in our health centers so that we see that these numbers really go down. Let's go ahead to, is it Godwin? I don't know. I can't see. Caroline. Yes. Karen, please go ahead and ask the question.
Enters. We talked about the polythene bags, and I know the ministry will take long to provide other facilities with the polythene bags. So how are we going to help this low birth weight babies and the preterms? Because are we allowed to use the bin liners, or there is a special polythene bag that these babies are supposed to be wrapped in? It's really a good topic that I've learned today, that we are not even supposed to clean these babies. We are just supposed to put in that big, that polythene bag, and then you transport to the next facility for the people who cannot manage them in their facilities. Thank you so much for the presentation. I'm really glad. Thank you.
Thank you so much, Carol. Dr. Sis is happy here to respond to you.
As we have already communicated this, that, and you've also said that the Ministry of Health is taking its time to avail these polythene bags even to the low healthy center, healthy center course. So what we are advocating for today is let's get transparent polythene bags. It doesn't matter the layer, and let's save these babies from hypothermia. The main reason as why we are not advocating for bin liners is the color. Because these babies, sometimes they even get, the baby's breathing, then you get secondary apneas. You may not notice. So you're advocating for transparent polythene bags. Please wrap this baby in that polythene bag, thinner, thicker, and then we control the temperatures. And then as we wait for Ministry of Health to give us better polythene bags that work.
Thank you so much, Dr. Sisi. Yes, someone was worried about suffocating the baby. No, we shall not suffocate this baby in the cavera. Usually we leave the face open. I hope you saw like in the babies that were, the visual aids that were in the presentation, the face are always out. We have another hand, then we shall go to Dr. Fidel from Moroto, Dr. Marithan, who will respond to that. But meanwhile, let's have Chiravo. Chiravo, you unmute. Please go ahead and ask your question.
Okay, thank you very much for today's CME. I really appreciate. Today we talked about hypothermia, but I know sometimes we get children getting hypothermia because of overcovering, others because of infections. But my concern today is sometimes we get hypothermia. Hypothermia because of neonatal sepsis or other severe infections. So how can we relate, apart from hypoxia and what we have discussed today, how can I relate neonatal sepsis to hypothermia and maybe simple management and assessment? Thank you.
Thank you so much. Yes, like we said a bit earlier, Barbara discussed the differentials of hypothermia. A baby can have hypothermia just because of environment, but sometimes the hypothermia is one of the signs of ongoing sepsis. However, it is a cascade. A baby who has hypothermia itself, hypothermia is a risk for the baby to have sepsis because of the reduced ability of the immune system because of that hypothermia. However, the hypothermia will kill the baby very fast because even if it's due to sepsis or it's the one bringing sepsis, it does not come with only one complication. It will worsen the hypoglycemia, and severe hypoglycemia kills faster than even hyperglycemia. So the golden rule is manage the hypoglycemia and look out for the cause. If you're worried about sepsis and baby is showing those other telltale signs of sepsis, take off your CBC if you can and start empirical antibiotics, but keep the baby warm, manage the hypothermia, then treat the sepsis if it's one of your top differential. Thank you.
Thank you so much, Dr. Rita. There's another hand that is Nabuire. You're unmuted, kindly go ahead and ask your question.
Thank you so much, the presenter and the moderator and the team for the presentation. I'm sorry if I'm going to ask a question which has been maybe probably answered, but I'm in a place with very, very poor network. I was so interested in this topic, but I've been on and off. My question is, where I'm working right now, it's a very hard to reach area with low income social status and all that. We usually get those preterm babies. Like yesterday, we had one who was weighing 0.9. And in those scenarios, you find that sometimes you don't have those transparent polythenes. But then a midwife taught me this because I didn't know, that you wrap a baby in thick cotton and gauze. That is just enough warmth. If you have a polythene, you add. So my question about this is that also being practiced elsewhere? Is it done the right way? Is it effective? Or is there something else we can add on to save our babies in these hard-to-reach areas? Thank you so much.
Thank you so much. Sharon, Dr. Rita, I would like to answer that.
Okay, thank you. So in the hard-to-reach areas, if the baby is preterm, let's do skin-to-skin care. If we do not have incubators, that is a cradle of life to me, if I can put it in my own terms. It's a cradle of life. Skin-to-skin, that baby will improve, so long as at least you've covered the cape and the feet are in some small socks if they can be afforded. However, also in case we get time, for example, if the mother comes in second stage, try to warm up the beddings or the sheets that are going to receive the baby. As you're preparing all this, put them under a radiant warmer or a heated light. If they are not yet available, as the mother does skin to skin, warm up some available bed sheets so that you use them. And of course, the basics like locking up the room and start D10 early, feed the baby early. If the milk is not there, start your dextrose early before the baby goes into hypoglycemia. Because if they have enough glucose, the body is going to try to regulate its heat production. But skin to skin is the way to go. About the cotton and gauze, we are not practicing it because you talked of the cotton, the gauze, then put the plastic if it's available. Heat can get lost through that cotton and the gauze, and these materials can absorb it, especially if they have not been warm. So if a plastic is available, it has to go into the baby direct. So let's avoid using the cotton. And also for infection control, my worry is that when cotton is available in most settings, We are pulling off this cotton to put under the mother for the pads. Like it's doing a lot of activities. If it's safe gauze, and there is no plastic, you can use. But the priority is skin to skin in our low resource. Close the windows and feed the baby on time. Give your glucose on time. This will help to fight hypothermia. As we won't get tired of advocating, the great news is that we have people from Ministry of Health listening to us in this room. So they are writing in capital letters. We shall advocate for plastics. They are not expensive. Kavera, just simple Kavera. Our government can do that. It's going to give us caffeine. It's giving us surfactants. Kavera cannot defeat our Ministry of Health with the way they are advocating for neonatal health. So let's be positive. Thank you.
Thank you so much, Dr. Rita. I think one last one that I feel Dr. Mary should comment about. It came in from Dr. Fidel, which is quite a common practice where we put warm water in gloves and put besides. Dr. Mary, kindly comment about that practice and how effective it is in case it is.
It's not one of the recommended practices to control hypothermia. Why? Because you do not provide heat globally. You can't provide heat to the whole rest of the body. And also it's associated with higher side effects like burns to the babies. So we wouldn't really recommend it. And you can't really monitor the temperature of this water in these gloves or in the jerry cans. So we wouldn't really recommend it. It's not recommended. We shouldn't practice it at all. We should advocate for kangaroo mother care.
Thank you so much, Dr. Mary. Thank you to everyone as we are coming to the end of our session. This has really been a very interactive session. There's a lot of learning that has taken place, I believe. Right about now, a CPD point link is going to be shared in the chat section. We shall also have a post-test to evaluate our learning, whether learning has taken place. At least I'm impressed that by the end of this session, everyone has known about the polythene bag. I think it has really stood out a lot. Thank you, our dear experts. You have really done us so well. Thank you for taking time off to share your knowledge with us. I believe from today, we are going to manage babies with hypothermia as our #1 priority in our care. Before I forget, I needed to comment about resuscitation. During resuscitation, warmth is really sometimes forgotten. Sometimes we tend to pay more attention to, is the baby breathing? Is the baby bleeding? We usually look at such things and we neglect the temperatures of this baby. How is the environment? You're resuscitating and the incubator is open because you want to see the baby, and instead the baby is getting hypothermic during resuscitation, and you end up with poor outcomes from your resuscitation. So even in resuscitation, please remember, let someone always be vigilant about warmth of the baby. So we've seen that in today's session that neonatal hypothermia is indeed a medical emergency. Another take-home message for today is we are going to do admission temperatures. I really like that one. We are going to do admission temperatures in our health facility. Whenever we receive a baby, first thing first, do the admission temperature. We need to come up with these projects. And when we are also advocating, you have some data. We need to do some research so that when we tell Ministry of Health that we need these polythene bags, we need this, we also have our data to back us up. So as we are sharing our CPD link, also make sure that you submit on the post tests. We have 4 questions and they're appearing on your screen. I hope you're able to access them. Those that are not, kindly check in polls, quizzes, so that you're able to answer them. Special thanks goes to Dr. Mary. Thank you. You've really done a very good job. I believe everyone has been answered. You may not have read out your question direct here, but I'm sure Dr. Mary took note of your question and you got the answer that you needed. Let's make use of the newborn networks that are available in case you have any questions about hypothermia. There's also a link that was shared for the previous sessions that Seed Global has been able to equip us with. Kindly visit that link so that you don't miss out on the new developments in the newborn care. Special thanks goes to Seed Global. Thank you so much for organizing this important session. I think we need to give Seed Global some flowers. And we need to clap for them. Imagine people from Morocco were able to join. And yes, I think this is really a beautiful thing and this is so far our 11th session. So we are really doing so well. Thank you so much, Seed Global. We appreciate you. I hope everyone is sharing their numbers for the CDP points, the license numbers, as we do so. Thank you so much for logging. We are almost coming to the end of our session. I will request Dr. Rita to give the closing remarks for this session. Thank you so much.
Thank you for moderating very well. And thank you, my fellow experts, Dr. Sisi, Sister Barbara. This was a nice session. Every time we have such a session, even as the experts keep learning from the comments coming from the participants and from each other. So we've added knowledge to saving neonates. To Seed Global and Ministry of Health, we are very thankful that you're spearheading this so that it can happen. Saving newborns is the in thing. So health workers, we should stay gumite, like the saying goes nowadays. Let's stay gumite, let's make that noise for newborns. Newborns cannot talk. Newborns are vulnerable. Sometimes when parents are asking for referrals or to go home, I ask them, how would you feel if your wife would say, today, waka, let them take you back home because I'm tired of being in the hospital and you're still sick. And they look at me and I say, this is how a newborn feels if we do not speak for them. So it is us health workers, and with hypothermia, it is coupled with infection control. Let's not ask the government even for neonatal ventilators, those mechanical ventilators, if they cannot give us plastic bags.
Sure.
Because even if I have the best ventilator in the world from Sweden, but I can't keep a baby warm, all the work I'm doing is useless. So warmth is everything. Even us, those who are married, when it's cold, you're busy cuddling, eh? But now these babies, how do we think they are going to survive? It is us to cuddle them. Warmth is everything. And as we go out there, let's remember that any decrease by just 1 degree from the normal temperature, of which hypothermia is when the temperature is less than 36.5. It doesn't have to be below 35.5. Anything below 36.5. Any decrease by just 1 degree from the normal increases the mortality by 75%. That is very high. So as we go back to work, every degree matters to keep a newborn alive. Thank you so much.
Thank you, Dr. Rita. Thank you, everyone. Thank you for joining in. We've come to the end of our session. Oh, you can turn on your videos. I'm requesting you turn on your video so that we can also say hello. And hello to the videos. Yes, hello. Then hello, hello. So that we are able to see you. Nice seeing you. At least say hello.
Oh, hello. Thank you for the presentation.
Thank you too. Thank you for joining in.
Thanks a lot. Appreciate we have learned a lot.
Thank you.
Thank you, Sister Barbara.
Presentation.
Thank you, team. Thank you, doctors.
Thank you
very much. Thank you for the presentation. It was so wonderful.
Hello.